Welcome back to my 10-part series where we review the top 10 medications given in emergency departments. This list was compiled as part of a study published in 2021, a link to which is available in my profile. Coming in at number 8 is Dilaudid. That's right, everyone's favorite analgesic, also known as hydromorphone, or that one that starts with a D. Next to a turkey sandwich, hydromorphone is probably the most requested thing in EDs everywhere. In Canada, its trade name is hydromorphone. Do you actually call it that? Its therapeutic class is opioid analgesic. Its pharmacologic class is opioid agonist. Now let's take a step back and talk about agonist versus antagonist drugs. Agonist drugs activate receptors to produce a biological response, while antagonist drugs block these receptors and prevent activation. Agonists turn receptors on, antagonists turn them off. For example, Dilaudid is an agonist because it binds to and turns on opioid receptors. Narcan, or naloxone, is an antagonist because it binds to and turns off or blocks opioid receptors. Dilaudid is used to treat moderate to severe pain. I've not seen any off-label uses. However, it does suppress the cough reflex, so if they're in pain and coughing, Big D's got you covered. Its mechanism of action: hydromorphone binds to opioid receptors in the central nervous system, causing inhibition of ascending pathways, thus altering the perception of and response to pain. And now we go down a rabbit hole, so hold on to your butts. What are opioid receptors and where are they found? Opioid receptors are proteins in the nervous system that interact with opioids. They're part of our endogenous opioid system. That's right, we have built-in opioids in our bodies. Wild, right? These receptors are found in the brain, spinal cord, peripheral neurons, and the digestive tract, and help regulate pain. Endogenous opioids, the ones our bodies create, include endorphins, enkephalins, and dynorphins, all of which play a role in pain relief and feelings of pleasure. They're just not as good as exogenous opioids, the ones we make. Moving on. Dilaudid can be given via every route, including orally, IV, IM, rectally, and sub-Q. In the ED, it's usually IV or IM. Onset of action for immediate release PO is about 30 minutes, IV, IM, sub-Q, and rectal onset is about 15 minutes, give or take. IV can work as quickly as 5 minutes according to UpToDate. Peak effectiveness for all routes ranges from 15 to 90 minutes, and the duration anywhere from 4 to 6 hours. Yeah, right. The most common side effects are hypotension, confusion, constipation, and sedation. The list of adverse effects is long, but those are the most commonly reported. If your patient is taking an MAOI inhibitor, which I don't really see much of those anymore, adding Dilaudid to the mix can cause severe and unpredictable reactions, so please use caution. As with any CNS depressant, be careful if they're already on medications that can cause CNS depression. We don't want to make it worse. Now, this next part is important and something that is not stressed enough in nursing school, at least in my opinion. When you give hydromorphone IV, you absolutely must push it slowly. The recommendation is over 2 to 3 minutes. If you push it too fast, it can cause increased respiratory depression, hypotension, and circulatory collapse, also known as shock. Now, you'll see a lot of nurses dilute IV opioids, but technically we shouldn't be. Now, our Dilaudid comes in 1 milligram per 1 ml pre-filled syringes. Suppose the provider orders a half milligram, or God forbid 0.25 milligrams. That's a tiny volume to push over 2 to 3 minutes, especially considering the extension tubing holds about 0.3 mLs. So you could push 0.25 mLs and it would all remain in the extension tube until you flushed it. A 2014 survey of more than 1,700 nurses showed 83% of those said they had diluted medications. The other 17% were lying. Just kidding, maybe. It's classified. The point is, we do it all the time, and that's not standard of care, and it's not recommended because of the risk of medication errors, impairing the efficacy of the medications, and possible contamination. As always, be familiar with and follow your hospital-specific protocols. Now let's talk about dosing, and this is where the comments section may get interesting. I cannot remember giving more than 1 milligram at a time to a patient in the ED, and that's if they have a seasoned ED physician. More often than not, it's half a milligram. Can I get a witness? Davis Drug Guide recommends 1.5 milligrams every 3 to 4 hours for adult patients weighing more than 50 kilograms. That's 110 pounds. UpToDate is even more conservative in what it describes as opioid-naive patients, recommending a paltry initial dose of 0.2 to 0.5 milligrams every 2 to 4 hours as needed. If the pain persists or is only nominally relieved, you can go up to 1 milligram every 2 to 4 hours. Remember, these are ED and adult doses. PEDS, PACU, and PCA dosing are different. I don't see pediatric patients, so if you work peds ED, those are typically weight-based, and I'll defer to my pediatric ED colleagues and their experience and expertise. One special population I do want to address, and something you will likely see at some point if you work in an ED long enough, is vaso-occlusive pain in sickle cell patients. If you get a patient experiencing a sickle cell crisis, check to see if they have a pain treatment plan on file. If they do, use the medication and dosing in that plan. If there is no plan on file, UpToDate recommends an initial dose of 1.5 milligrams within 30 to 60 minutes of arrival, followed by a dose 20 to 50% less than the initial dose in another 30 minutes. And once again, this episode is not meant to be a comprehensive review of hydromorphone, but I do hope you find it useful. If you have any questions, please ask. If you have corrections, suggestions, or stories you'd like to share, please do so in the comments. This script is available for anyone to download and use at the following link, which is also available in the description. I appreciate you watching. I would be honored if you liked this post, shared it with your friends, and especially grateful if you followed me for more nursing-related content. In part 4 of this series, we'll talk about number 7 on the list, morphine, the OG opioid. Thanks for watching, and I'll see you next time.